Well, thanks, everyone. I'll add my thanks to Dr. Karpecki and the meeting organizers for our invitation to come and present and give you a little update on how we are transforming the treatment of diabetic retinopathy using a topical therapy for retinal disease, beginning with DR. We're a company based in Boston. We are going after transformational therapies in terms of treating diabetic retinopathy because there is an unmet need. Right now, there are two injectables that are approved. Lasers can be used. I think patients need something that's non-invasive, and we think a topical therapy is exactly what patients are looking for. Our lead asset, OTT-166, is a first-in-class non-invasive treatment using the mechanism of action of integrin inhibition to treat diabetic retinopathy. We are in our phase 2 study, and you'll hear more about that in the coming minutes. We are fully funded for our phase 2. We have raised over $35 million. We are well positioned to finish our phase 2 study, and we're actively enrolling as we speak. And I'm proud to be associated with a mission-driven team of executives based in Boston who have over 100 years of experience in this space. So diabetic retinopathy, progressive disease, it puts patients at risk, there's no question. Vision loss is a top concern for them. It's amazing that the prevalence of diabetic retinopathy in patients such as 30% in type 2s and 80% in type 1s really is something that they're quite concerned about, obviously. And this isn't just a US disease, this is a global disease. In the year 2045, there'll be 700 million people suffering from diabetes. 25% of them, or over 160 million people, will have some form of a diabetic retinopathy. So while it's prevalent in the US, it's a global disease, and we think a non-invasive treatment is appropriate for everyone. So when patients present with moderately severe to severe NPDR to a doctor's office, especially when they don't have DME or vision loss, it really presents a difficult situation. Do you watch and wait, which is the preferred practice pattern by numerous authorities, or do you bite the bullet and start doing invasive treatments such as intravitreal injections and lasers or both? What we're doing at OcuTerra is developing OTT-166 as a non-invasive treatment option that will, I think, shift the paradigm in the treatment of diabetic retinopathy. It'll enable earlier active treatment, not just watching and waiting. It will expand the prescriber base because anybody that can prescribe a topical therapy can utilize this or consider it for their patients if appropriate. We think it'll improve the eye health and prevent disease progression, which is an important aspect of this disease, and potentially reduce barriers to patient care. So how are we doing it? We are purpose engineering OTT-166 to transform the management of diabetic retinopathy by giving it two key characteristics. We'll talk a little bit about the anti-VEGF effect, but this is an anti-VEGF plus. There's more than just an anti-VEGF because we know that just targeting anti-VEGF really leaves a lot of treatment on the table in terms of not being addressed appropriately. We know diabetic retinopathy is a multifactorial disease. More on that in the next slide. We also want it to be non-invasive, obviously, and that will benefit patients and prescribers alike. So again, diabetic retinopathy, there are multiple drivers of diabetic retinopathy. There's angiogenesis, there's exudation or leakage, there's inflammation, and there's fibrosis. All these aspects of this disease are mitigated or managed or controlled, if you will, by integrins. And we know that OTT-166 as an integrin inhibitor blocks all 7 of these integrins that are associated with this multifactorial disease. Therefore, we believe it's an anti-VEGF plus, and will have a broad efficacy here. How do we do it? It was purpose engineered to have favorable physiochemical properties to be used as a topical therapy that gets to the back of the eye. One of the aspects is selective fluorination. We did a lot of work on properly fluorinating this compound in different areas of the molecule. We found the right combination to give it the appropriate physiochemical properties for topical therapy to get to the retina and have a therapeutic effect. One of the studies in our compendium of preclinical work here is the distribution study here that you can see. It was in a rabbit model, a single drop of OTT-166 placed on the surface at 12 hours. You can see selectively higher concentrations of this therapy in the sclera and the retinal choroid complex, significantly higher. In fact, it was over 200 times above the IC50 that's required to block one of the key integrins, and significantly higher than what we see in the vitreous, the aqueous, or the plasma. So that tells us it's getting from the top of the eye through the transconjunctival transscleral route, or an outside-in mechanism of delivery, getting to the retina to have its therapeutic effect. So on all that work, that preclinical work has been published. So we conducted a first-in-human study in patient population that had diabetic retinopathy, but also had diabetic macular edema because we needed a biomarker for efficacy, of course, with our primary endpoint being safety and tolerability in this phase 1 study. 40 patients were selected, randomized into 2 different groups, a 2.5 and a 5% solution. Each group dosed just twice a day for just 4 weeks, and then they were followed for an additional 4 weeks. Safety and tolerability was certainly met. There were no serious adverse events that were drug-related. No patients stopped the therapy, and so the primary endpoint in this study was met. Secondary endpoint of evidence of biological activity was also met, in that we had 3 retina specialists, who I'll introduce you to in just a couple of minutes, looking at all of the OCTs at all time points out to 8 weeks, and looking at them as a clinician would for evidence of efficacy. They've been the groups into 2 groups, a 35% responder population that you can see with both mean and median reductions in a clinically and statistically significant fashion in terms of the mean CRT, central retinal thickness, at baseline out to 28 days at end of treatment and day 56 at end of study. The non-responder patient population also showed an interesting phenomenon. And again, they were only dosed 4 weeks, but they did show a deepening of effect, in that median response of reduction in the central retinal thickness did drop below baseline at day 56, end of study. Here are 3 case examples showing significant reduction in the mean, in the central retinal thickness of these patients, anywhere between 25 and 50% at day 56, end of study, compared to baseline. Again, showing clear evidence that this drop is getting to the retina from a topical distribution and having a biological effect. So this has given us confidence to move into our phase 2 study, which we're actively enrolling in now, which is our DREAM study for diabetic retinopathy, early active management, as opposed to active surveillance, which most people are getting now. It's a randomized, double-masked clinical or vehicle-controlled clinical trial. We'll enroll 210 subjects with moderately severe to severe NPDR or mild PDR, 47s, 53s, and 61s on the DRSS scale. They'll be randomized into 3 groups: a high-dose OTT group, a low-dose OTT group, and a vehicle control group. They will also have fairly good visual acuity, and the primary endpoint will be a very well-established clinical and regulatory endpoint for this DROP study, which is a 2 or more step reduction in the severity of diabetic retinopathy at 24 weeks compared to baseline. A host of key secondary endpoints, including the prevention of progression to vision-threatening complications, delayed time to rescue therapy, as well as some interesting novel imaging-based exploratory endpoints, including OCT angiography. Our top-line results should be presented a year from now, in the first half of next year. So in summary here, I'm proud to be a part of this team with, again, over 100 years collectively in this space in ophthalmology, clinical development, and business development. We're also supported by a very strong board of directors led by Brent Saunders, who is our chairman. And we have a scientific advisory board, including the 3 retina specialists who looked at all the OCTs in our phase 1 study. We also have 2 well-known comprehensive ophthalmologists, and we also have Dr. Paul Karpecki, who is representing the optometric community on our scientific advisory board. We also have a study steering committee that's led by Carl Regillo, who is the chief of retina at Wills Eye Hospital. He is our principal investigator. We also have Dr. Paul Chaus, who is a well-known expert in diabetes and diabetic retinopathy on our study steering committee. So again, I'm privileged and proud to be representing OcuTerra here. I look forward to bringing you key updates as we develop our program, and I thank you for your kind attention.